Good afternoon. I'd like to thank Dr. Sinnaby and Dr. Slutsky for inviting me to talk here today. I figure the reason I was invited is because you had to have at least one speaker without an accent. A couple of disclaimers. I know these were said in the beginning. NAVA is made by McKay. We'll go with that. I have no commercial interest in McKay. I don't own anything, stock or equipment. We didn't receive any support from McKay to do any other studies, any other data I'll present to you today. I made a concerted effort not to take support from them and to do it all through the hospital. I come from Toledo, Ohio, not Toledo, Spain. I've never been to Toledo, Spain, one day. We are level 3 NICU. We have 60 beds. About 70% of our babies are inborn, 30% outborn. And in 2011, we had more than 800 admissions in a year and run an average daily census of about 40 to 45 patients. So we are on the larger, busier side, but we're certainly not the largest or busiest units out there. There's some units that are 2 to 3 times our size. When we started off in the, with our NAVA experience, we started in 2008. So if you look at 2008 here, our neonatal studies to go and look at were extremely limited. In 2009, we had another one come out, and then in 2010 and 11, more studies in the neonate are coming out. Now, the NAVA studies in general came out pretty fast, much faster than this, but in the neonate, we were very limited. Sample sizes varied from 3 to 52 patients, and the 52 patients was from our unit. Time on NAVA in the studies were as little as 10 minutes to as much as 24 hours. And the ages were from 26 weeks to teenagers. And many other studies had a mix of neonates and children. Very difficult to just shake out what's going on in the neonate. In general, they showed that NAVA improved patient ventilator interaction and synchrony in neonates, even in the presence of large leaks, which was very important to us because neonates usually have uncuffed endotracheal tubes, so even the intubated babies have very large leaks. Peak inspiratory pressures decreased when changing from conventional ventilation to NAVA, and we saw that earlier this morning in the adult world as well. And the respiratory rate increased when you went onto NAVA in some studies, decreased in others, and remained the same on others. So we know exactly what's going on there. And blood gases improved on NAVA in some studies and remained the same in others. So we're very early in the neonatal literature of what happens to these babies. None of these studies have looked at long-term outcome. There's no change in mean airway pressure, and importantly, to this point in time, no adverse events have been noted that have been attributable to NAVA. At Toledo Children's, we've been using NAVA since May of 2008. We've done almost 400 babies on NAVA and about 15 pediatric patients on NAVA. One of the pediatric patients we had in our NICU, he was born with severely hypoplastic lungs from prolonged rupture of membranes, and he basically came out with a picture of chronic lung disease. NAVA was the only way we could ventilate him in the NICU, and when he hit about 5, 6 months old, we moved him up to the PICU. He's now 13 months old. He's been on NAVA about 10 of those months. He comes off occasionally. Question?
Something wrong with the microphone?
Something happened to me? Back on again? Yeah, it must be. Otherwise, good? All right. I have 3 sons, so I'm very used to yelling, so I just gone into father mode. So our PICU experience is somewhat limited, but we are now starting a protocol upstairs, and hopefully that will encourage them to start using it more. When we first started out, we had questions in neonates. We had an opportunity to look at areas of a baby's neuroventilatory pathway that we'd never seen before. So the questions we had was, is central apnea really central in these babies? We've always called it central apnea. We've never really known for sure. Is SIMV in preemies really synchronized? And is the neural trigger synchronous? So starting off with apnea. Here we have a baby, and you've seen these screen dumps before, where they show complete flat EDI signals. And we've always interpreted this in the adult world. We call this over-assist, that we have no EDI signal, or we have a paralyzed patient with no signal coming down to the diaphragm. But in our preemies, this is not an uncommon finding at all from apnea of prematurity. No EDI signal, and the patient is controlled for every breath. And if you look at a trend graph going on for 3 hours, you can see we have periods with excellent EDI interspersed with periods of no EDI at all. So these patients truly have episodes of central apnea, and we have now learned how to adapt NAVA that we still use it very effectively on these patients that are having significant central apnea. Is SIMV really synchronized? Well, we've talked about this in the adult world all morning. In the neonatal world, we have the same issues going on. Here we have a baby on SIMV with pressure support, and you can see the purple lines here, and it means that these are all flow-triggered breaths, the pressure-controlled breaths here, the pressure support breaths here. And if we walked up and looked at this patient here, we'd be very proud of ourselves that we have this patient beautifully synchronized, all flow-triggered breaths with a wonderful pressure tracing on the top. Once we superimpose the EDI signal over here, we can see that we are way off. We do pretty well with breath initiation because that's all the flow trigger synchronizing is breath initiation. But our volume synchrony is way off in some periods. Here we have volume synchrony pretty good, but our termination synchrony is terrible. Here we've got not much of a trigger at all. So, and yet we give the baby this really big breath. So our synchrony is very, very poor. Here we have a baby, again, that is apneic. This is a baby that is getting pressure control breaths because he is not initiating flow at all. Not a baby that I'd want to consider weaning or extubating. As soon as I put the EDI signal over, I can see that we have an excellent EDI signal, and these are all missed triggers or failure to trigger. No reflection on the servo eye. This is just a baby problem. So is our neural trigger synchronous? Well, we did a study where I looked at, I'm going to show you the data in a little bit, EDI values in term babies. And what we wanted to know was in term extubated babies that are not on any ventilatory control, what are the EDI numbers? And those numbers have not been available at all. So I got permission. It took me 6 months to get 3 mothers to allow me to put an NG tube down a perfectly healthy, normal term baby. But eventually 3 mothers consented to this. And one of them allowed me to do some video as well. So you've all seen the tracings that go along with synchrony. But here's a video of a baby with NAVA. So he's got the NG tube in place, hooked up to a test lung. And if you just watch the chest to the test lung, we are in perfect synchrony. Nice, happy, sleeping baby. So how good is our EDI signal? We've talked about that this is looking for electrical activity, and there's lots of stuff going on in the chest. We have cardiac contraction, we have esophageal tone, we have the sphincter, we have muscles from breathing. How much interference is coming through? The next thing we did was we decided to video the baby while feeding. Did I lose sound again? Does it come and go? Oh. All right, we'll try it again out there. So here we have a baby that's feeding from a bottle, sucking and swallowing. And what does that do? And if you watch as a reflection up here at the test lung, you can see our synchrony again is perfect. Even though we're sucking and swallowing, there's no interference to our signal. Whenever I show this, I offer this to people in the audience that if you are someone who's really into studying, feeding, sucking, swallowing, and breathing, this is the perfect technology to do this. Really gives you a window to what's going on. Cute baby. All right, some harder data. What we're going to start off with is some normative data from term babies and from preterm babies. And this is what I was alluding to earlier when you were talking about, can we match EDI signals from patient to patient? And if we can, do they mean anything? Retrospective review of babies less than 1,500 grams, our most vulnerable patient population, the ones that we're ventilating most commonly, and the ones that develop chronic lung disease. And chronic lung disease for us in the NICU is a huge problem, not only from a respiratory standpoint, but from a developmental standpoint. And babies with bronchopulmonary dysplasia or chronic lung disease go on to have major problems the rest of their life. And can be a very expensive and time-consuming burden to the parents. So if we can impact that, that'd be very good. And then we did a prospective controlled study in very low birth weight infants between NAVA and pressure controlled ventilation. So why is normative EDI information important? When we've seen already from these other studies with the NAVA titration studies that we can manipulate the EDI for patients on ventilators. The more we unload the patient, the higher the NAVA number, the more we can suppress the EDI. We can over-support the patient to a point where there's no EDI, and we can under-support the patient to the point where the EDI values are huge. So on the ventilator, I really believe there's no such thing as normal EDI signal. It's all related to the amount of support that you supply. So off the ventilator, we're not really varying support, so you get what you get. Also, if we can get some normative values, this may give us some guidelines where to move on the ventilator. For example, if you've got a patient with an EDI of 30, having some normal values may tell you that this patient requires more support. On the other hand, if your EDI value is 3, maybe you need to back off on your support. And we've all kind of said that intrinsically, but these are hopefully numbers to give us some guidelines. So we talked about underventilation, too much overventilation, suppressing it. So this will give us a range to work towards when we are NAVA, adjusting the NAVA level to provide how much unloading we're going to do for the patient. And also on conventional ventilation, knowing what normal values are will give us an idea how much conventional ventilation to adjust to achieve these normative values. So we started with our babies, 37 to 41 weeks, our term babies. I managed to get 3 willing moms to let me do this. We looked in the first week of life when there was no respiratory disease. And what we saw that our values varied from about 10 to 15 for peak EDI and about 2 to 4 for EDI min. And the rest of the here is showing what the babies look like when they're awake, they're asleep, pre-prandial, during feeding, and then the purple is post-prandial. So there were some statistical differences, but clinically, they're all still falling in that 10 to 15 range in term babies. We then moved to preterm babies. And what I did with this was I enrolled babies starting as young as 24 weeks as soon as they got off the ventilator, off mechanical ventilation. So on conventional ventilation and CPAP, they weren't eligible. But once they went to high flow, nasal cannula, or room air, we had them in the study. And what we did was we started as young as we possibly could, and then studied them weekly until they no longer needed a nasogastric tube. And this was a much easier study to recruit for because all these babies required nasogastric tubes. So what we found is, here's our EDI peaks and our EDI mins in black over here. And what we're looking at is from 26 weeks up to 36 weeks gestation. We enrolled 17 babies for these studies, and we followed them along. So all in all, I have 96 4-hour studies contributing to this data. So 96 times 4 is almost 400 hours of EDI data that we downloaded to get these values. And we found that there was some real consistency, not only from within one patient over time, we saw no changes, but from baby to baby. Values fell, again, between about 10 and 15 for EDI peak and about 2 to 4 for EDI min. When we broke it up between high flow nasal cannula, regular nasal cannula, and room air, and it's a busy slide, the white being EDI, the solid bars being EDI peak, the open bars being EDI min. The white is high flow, the red is regular nasal cannula, and the yellow is room air. And the only reason I leave it as a busy slide is because statistically there was no difference between whether the baby was on high flow, regular or nasal cannula, or room air, and there was no difference over gestational age either. And that tells me again that we are giving these babies support, whether it's with high flow at 5 liters per minute or room air with no support, we're titrating them to comfort. We're making sure that their CO2 is okay, their respiratory rate is reasonably in the normal range. We looked at that. All these kids had respiratory rates, heart rates, and SATs within the normal range for gestational age as well. So we were titrating to comfort, and indeed, the EDI signals fall in the same range as well. My suspicion was that when you were on high-flow cannula, you may have had a higher EDI signal because your respiratory drive was increased, and that's why you needed the high-flow cannula. And that was probably true if I took the high-flow cannula away. But once the baby was on high flow, we found that the EDIs came into the normal range. Now, again, we did not titrate any of the support to a certain EDI. This is purely an observational study. Our preemies less than 1,500 grams. Over the first year that we used NAVA, I did a retrospective review where I looked at 52 neonates less than 1,500 grams. Half of them, well, just over half, about 60% had RDS, and 40% had chronic lung disease. Gestational age averaged about 26 weeks. So again, the smallest babies that we take care of, birth weight about 837 grams. We studied babies starting at about 15 days of age and a weight of about 960 grams. And what we did was again, retrospective review. We started with the babies on SIMV, and then they were switched to NAVA at the discretion of the treating physician. This is the first year where we said, this baby looks like a good baby for NAVA, let's give it a shot. So we put the baby onto NAVA, and then I came back and I pulled the data for the first 24 hours. And then compiled it all together. And we saw that our FiO2 dropped statistically from about 32% down to about 26, 27%. And that drop was sustained for the first 24 hours. And at that point, many of our babies had been extubated. So I didn't look any further than that because I ran out of numbers. Peak pressure dropped from 17 down to 13. And that difference was sustained as well. And that's about a 20 to 25% drop in peak pressure, which in our fragile babies is a huge drop in pressure and may become significant as time goes on to eliminating barotrauma. So here we have babies that are on less oxygen and are getting less pressure. Their respiratory rate, mean airway pressure, and other variables we looked at were really unchanged. So our gains were less FiO2, less pressure. So what did we get for that? Well, in the babies that were acidotic, and they were acidotic deliberately, 7.29, because we use a strategy in our NICU called permissive hypercapnia or hypercarbia, where we underventilate babies to pHs of 725 to 730 to try and minimize their barotrauma. Their enzyme systems are quite happy in that acidotic range. So we'd love to have them have a normal pH, but the cost to their lungs to generate that normal pH is so prohibitive that we allow them to have this permissive hypercarbia. So many of our babies, 33 of the 49, we had got into the permissive hypercarbia range. And once we put them onto the NAVA, we had less barotrauma by about 25%, yet pH went up to 732 and to 734 by 24 hours of age, and CO2 came down from an average of about 54 down to 47. Those that had normal pHs remained normal on NAVA, and those few babies that were overventilated on conventional ventilation brought their pH and PCO2 down into the normal range on NAVA. Importantly, we saw no adverse effects, no increase in interventricular hemorrhage, which was a concern in the beginning because of the same observation in adults of variations in pressure from breath to breath or variations in volume from breath to breath. We see this very variable respiration in neonates as well. I heard the term used, chaotic respiration in adults. In neonates, we call it just variable respiration, and this is normal. Every one of our babies can go from taking a pressure of 8 to a pressure of 32 and back to a pressure of 10 in the case of 3 breaths. So huge variability. We were concerned about flow to the brain. Could that cause interventricular hemorrhage? No difference. No difference in pneumothorax, and no difference in NEC or perforation. And again, a concern because we were using NAVA catheters, which had not been really tested extensively in babies before. And we were positioning them not to position in the stomach, but we were positioning them to position around the diaphragm. So in our 400 grammers, we had almost 1.5 loops in the stomach. And in our 1,200 grammers, there was the appropriate amount in the stomach. So we wanted to make sure that all that excess catheter in the stomach wasn't causing problems. And we have not seen any problems from that, even up until now. The other question that came up, and it's been raised in some of the papers that I've looked at, is how easy is it to put the NAVA catheter in? Well, on ventilated babies, we've done about 500, 400 or so babies, of which some of them have required 7 or 8 catheters if they've been on NAVA long enough. And we have not had any problems putting catheters down. Sometimes they do coil in the esophagus. We got to take them out and put them back in. But I would say that would happen maybe 1 out of every 100 catheter insertions. For the NAVA study that I showed you on normative preemies, we did 96 studies, 96 catheter insertions, 100% success rate getting them in. So as long as I'm not doing it and we leave it to the therapists and nurses who are extremely good at this, it's really effortless. And from placement of the catheter to positioning correctly at the diaphragm takes them under a minute. The first prolonged prospective study that we did in our babies, we did NAVA ventilation for 4 hours. We then flipped them over to pressure control for 4 hours, and we adjusted the pressure to keep them in that permissive hypercarbic range. And then we repeated that cycle for 24 hours. So I sat there as we went from NAVA to pressure control to NAVA to pressure control, NAVA to pressure control, trying to use each baby as their own control as we moved back and forth between the two modes. We studied 5 babies. Gestational age was about 26 weeks. Birth weight 810 grams. We studied them at about 3 weeks of age. And what we found is our driving force for our pressure when we went back to pressure control was transcutaneous CO2. So the yellow for all these slides will be pressure control. The red will be NAVA. So in pressure control ventilation, we achieved our hypercarbic mark. When we allowed the babies to regulate their own CO2, they dropped their CO2 significantly by about 10 to 12% to CO2s in the mid to low 50s. So for that decrease in CO2, what did it cost us? Well, on pressure control ventilation, we were ventilating again with 15 to 20% higher pressures to get higher CO2s than we were when we allowed the babies to regulate their own pressures with NAVA. EDI, on NAVA, EDI is what it is, but on pressure control, EDI is just a variable that we follow. And not surprisingly, we saw that EDI was higher on NAVA, and that was probably because the higher CO2 was driving the baby's respiratory drive up to try and blow off that CO2, although on pressure control ventilation, they weren't able to do it. Compliance, much better on NAVA. There was a significant increase with compliance on NAVA compared to pressure control ventilation. FiO2, statistically different, although it seems like a small difference when we look at numbers. It's only a difference of maybe, a couple of percent. But statistically, it came out mostly because of the amount of data points that we looked at. Respiratory rate, studies have shown that respiratory rate goes up on NAVA. Our study showed that actually respiratory rate came down on NAVA. These babies had lower pressure, lower respiratory rates. So they actually had lower minute ventilation to end up with lower CO2s. And we can talk about why I think that may have happened. EDI min was higher. They were generating more tonic activity of the diaphragm when they were on NAVA compared to pressure control. And mean airway pressure was unchanged. And there's a variety of reasons that I think that happened as well. So in conclusion, babies appear to have an intact neuroventilatory coupling with functional feedback pathways. They do it right. They ventilate on NAVA with lower peak pressures or lower tidal volumes and lower FiO2 than on conventional ventilation. They have improved blood gases on NAVA despite ventilating with lower pressures, and they have improved compliance on NAVA. No adverse effects have been noted on all these babies we've had on NAVA. Now, that doesn't mean we have never had a baby with a pneumothorax on NAVA. We have had babies get pneumothoraces, pneumopericardiums while they've been on NAVA. But when I've looked at them compared to the rest of our unit, we have just as many babies who have never seen NAVA, and in fact, many of them who've never seen a ventilator, who also end up with pneumothoraces or pneumopericardium based on their disease. Hyaline membrane disease or surfactant insufficiency puts them at risk for air leak. So I am convinced from this data that NAVA works in neonates. It does what it's supposed to do. What I don't know is, does it make a difference to outcome? And this has been brought up repeatedly. And the only way we're going to get to this is, again, multi-center trials in neonate. And fortunately, in the neonatal world, we are very well equipped to do this. The NICHD and Vermont Oxford are both huge networks that have hundreds and hundreds. I think Vermont has 800 plus NICUs in it that all participate in these multi-center trials. So if we can get them motivated, and the more of this basic science data that we can put together, or clinical data we can put together, the more basis they have to put a multi-center trial together and do this throughout the country, if not throughout the world. And hopefully we'll answer these questions. If NAVA can prevent intubation which would be ideal in our neonates, and we'll talk about that in the next lecture, or decrease our time on ventilators. As I said again, have a huge impact on the incidence of chronic lung disease, and that will have a huge impact on our long-term neurodevelopmental outcomes. Thank you.
Thank you. Thanks very much, Howard. You presented a lot of data, a lot of interesting data. Well, a little behind schedule. I just have a quick question. Your EDI data, where you showed it's about 15, I didn't know if there was standard deviation. So what's the range? Because to say that it's around 15.
Yeah, the range that we saw went from about, the EDI peaks went from about 3 to 18. So we saw this very wide variety from baby to baby to baby. And I know it sounds, we could make the argument. What I did see, which I didn't show you, is when I divided the babies between the AGA babies and the SGA babies, the AGA babies ran EDIs of peaks of about 12 to 14, and the SGA babies ran EDI peaks of about 8 to 10. So there actually was a statistical separation between the SGA and the AGA babies. And again, there's all sorts of theories why that could have been happening as well. So our ranges were quite wide, but again, the numbers are still in that range of what we've heard all morning, somewhere between 10 and 15.
Might be worth presenting that as interquartile ranges, or 10 to 90% or something.
Yeah, well, I threw up the standard deviation bars there, but I'd be open to any statistician who can steer me right.
Antonio, yes. One question?
Yes. Thank you for this very exciting lecture, really. Regarding the peak inspiratory pressure, do you have any idea about transpulmonary pressure in this patient? Second question, how did you measure compliance?
To answer your first question, I don't have any sophisticated measuring devices. In fact, this answers both your questions. I don't have any sophisticated measuring devices. The only way I got all this was to take it off the servo eye. So the peak pressures come off the servo eye. Pulmonary pressures, I don't have a way of measuring that at all because I don't have an esophageal balloon or any access to that. Compliance, the same answer. I went to the servo eye download and I took that number from there. Now, that opens up the whole question is how accurate is a servo eye for measuring compliance? I don't put much credence on the numbers that I got. 0.3 to me wasn't that useful. But whatever error there was in the measurement, I would figure would be the same measurement on error on NAVA that there would be on pressure control. So to me, the change would be a significant issue, even if the absolute number could be, somewhat suspect. I just don't know. I can only work with what I have.
Thank you.
Thank you.